You inhale and exhale, what, 20,000 times a day? Completely on autopilot.
Yeah, it really is an autonomic marvel, if you think about it.
Right. It's this constant background hum of oxygen and carbon dioxide exchanging in that microscopic architecture of your chest. But deep in that invisible architecture, a single cell might just be quietly rewriting its own code.
And that silent rewriting is exactly what we are mapping out today.
Exactly. Welcome to today's deep dive. For this session, we are relying on Dr. Walter J. Scott's definitive medical text, Lung Cancer, From Diagnosis to Treatment. And our mission for you today is to provide a thorough, scientific, yet totally accessible summary of that entire clinical pathway.
Right, from cellular pathogenesis all the way to, the most cutting-edge systemic treatments.
So we are going to trace how a single rogue cell becomes a lethal malignancy, how it evades detection for so long, and how modern medicine actually hunts it down.
Because, cancer is essentially a progressive biological failure. It doesn't just appear overnight.
It takes time.
Yeah, a lot of time. According to the text, a pulmonary malignancy typically results from 10 to 20 successive genetic mutations.
10 to 20.
Yeah. The cells lining your airways are constantly producing, right? They have to repair daily wear and tear. But when they are repeatedly exposed to inhaled toxins, normal cells first undergo a state we call hyperplasia.
Hyperplasia. So what does that actually look like?
Well, it basically means there is an abnormal increase in the sheer number of cells.
So the body is essentially overreacting to the damage by overproducing cells just to patch the wall.
That's a great way to look at it. But that overproduction creates a really crowded environment. And as the toxic exposure continues, those crowded cells undergo dysplasia.
Okay, dysplasia.
Right. They aren't just numerous anymore. Their actual physical structure becomes abnormal and completely disorganized.
So this is the precancerous stage.
Exactly. And if that DNA damage continues through those 10 to 20 mutations we talked about, those dysplastic cells transform into outright malignant cells. And those are capable of invading surrounding healthy tissue.
It sounds a lot like bad computer code. Like one glitch, the program crashes, the body clears it out, and you move on.
Right.
But if you get 10, 15, 20 specific compounding glitches, it doesn't just crash the software, it rewrites it entirely. It basically turns the pulmonary cell into a rogue machine whose only instruction is just to multiply uncontrollably.
That compounding glitch is perfectly stated. That's exactly what we see under the microscope. And clinically, we categorize these rogue machines into two main camps based on their cellular appearance and behavior.
Okay, so what's the most common one?
The vast majority, so about 80% of cases, are non-small cell lung cancer, or NSCLC.
NSCLC, got it.
And within that group, the most common form is adenocarcinoma. These typically arise out in the periphery, so the outer edges of the lungs, originating in those tiny alveoli from mucus-producing glands.
Okay, so if adenocarcinomas are hiding in the outer edges, where are the rest of them setting up camp?
Well, squamous cell carcinomas, which is the other major type of NSCLC, they generally arise centrally.
Centrally, meaning in the main pipes?
Exactly, right in the main bronchial tubes. They originate from the squamous cells that line those larger airways. Yeah. And then we have the remaining 13% or so of lung cancers, which are categorized as small cell lung cancer, or SCLC.
Small cell. Okay, that's the one with the really terrifying reputation, right?
Yeah.
It's incredibly aggressive.
It is notoriously fast-growing, yeah.
Mm-hmm.
It also arises centrally in the airways, much like squamous cell, but its cellular doubling time is just incredibly rapid.
Wow.
Yeah, so by the time a patient actually walks into a clinic with SCLC, the cancer has almost always spread to the mediastinal lymph nodes in the center of the chest, where it's already, escaped into the bloodstream.
Let's pivot and talk about the etiology. What is actually causing these genetic glitches in the first place? The statistics from the sources are heavy. The lifetime risk is 1 in 13 for men and 1 in 16 for women.
And the average age of diagnosis is 71.
Right. And obviously, we all know cigarette smoke is the primary culprit. It causes 80 to 90% of all cases.
It does. Because cigarette smoke is essentially a delivery system for over 4,000 distinct chemicals. And at least 50 of those are known highly potent carcinogens that are just bathing that airway tissue.
But the text also highlights some really crucial environmental factors that I feel like often go ignored. like radon.
Yes, radon is actually the second leading cause.
Which is crazy because it's just this odorless, invisible gas. It's created by the radioactive decay of uranium in the soil, and it can literally just pool in residential basements.
Exactly. People don't even know they're breathing it in.
Yeah.
And then there is asbestos.
Oh, man, asbestos. This introduces a terrifying multiplier effect because, okay, if you work around asbestos, your lung cancer risk naturally goes up.
Right.
But if you are exposed to asbestos and you also smoke, it's not just additive.
No, not at all.
Your risk of developing lung cancer is multiplied by 50 to 90 times compared to a non-smoker.
Yeah, 50 to 90 times. It's staggering. And the reason is those physical asbestos fibers lodge deep in the lung tissue, and they create this state of constant inflammation and scarring.
So the tissue is already compromised.
Right. So when you introduce the chemical carcinogens from cigarette smoke into that already highly inflamed environment, the rate of genetic mutation just accelerates exponentially.
Okay, so we have these tumors growing either centrally in the main pipes or out in the periphery of the lung tissue. And the structural reality explains something that, honestly, completely baffled me at first.
The silent symptoms.
Yes. How lung cancer can be so notoriously silent. I mean, the sources state that 25% of patients have absolutely zero symptoms when they are diagnosed.
Zero. Their cancer is almost always found, incidentally.
Like they go to the hospital after a minor car accident or something.
Exactly. They get a routine chest scan for something else entirely, and boom, a massive mass is discovered.
But wait, this is what I don't get. If my lungs are filling up with a tumor the size of a golf ball, how do I not feel that? Like, I get a paper cut, and it hurts for 3 days.
I know, it seems wild. But it all comes down to basic anatomy. The spongy lung tissue itself, the parenchyma, it has no nociceptors.
Nociceptors being pain receptors.
Right, no pain receptors at all. You literally cannot feel a tumor tearing through the center of your lung lobe. The pain only registers if the tumor grows large enough to reach the outer edge and irritate the pleura.
And the pleura is the lining around the lungs.
Yeah, it's that tight envelope or lining surrounding the lungs and the chest cavity.
Because the pleura actually is wired with nerves.
Highly wired. So when a tumor rubs against that lining, it causes pleuritic chest pain. It's this sharp stabbing sensation that spikes violently every single time the patient takes a deep breath in and expands the lung against that irritated wall.
Okay, so if the lungs can't feel pain early on, we really have to rely on other red flags. For central tumors, the ones growing inside the main breathing tubes, the symptoms make pretty logical sense.
They do. The mass physically irritates the airway, which causes a relentless, persistent cough.
Or it blocks the airflow, right, creating localized wheezing.
Exactly. And if the tumor surface ulcerates and bleeds into the airway, the patient presents with hemoptysis, which is coughing up blood.
Okay, those are the straightforward presentations. But the truly bizarre clinical presentations, and the text goes into some fascinating detail here. These occur when tumors grow right at the apex, the very top of the lungs.
Right, the apical tumors.
Because the space just above your collarbone is this anatomical bottleneck. It is crowded with major nerve pathways and blood vessels. So when an apical tumor expands, it starts crushing those adjacent structures, creating what we call paraneoplastic syndrome.
And this is where clinical diagnosis feels a bit like a detective novel.
Totally. Like a patient comes into the clinic complaining about a droopy eyelid and severe armpit pain, and the doctor's like, you have lung cancer. That feels completely disconnected.
It does, until you trace the nerve pathways. Let's look at Horner syndrome. You have a sympathetic nerve chain that runs right down alongside your spine, passing the top of the lung.
Okay.
This nerve chain controls your fight or flight responses in your face. So it dilates your pupils and makes you sweat.
Oh, wow.
Yeah. So if a lung tumor compresses that specific nerve, the signal gets cut off. The patient presents with a drooping eyelid, which is called ptosis. Their pupil remains permanently constricted, known as miosis, and they lose the ability to sweat on that entire side of their face, which is called anhidrosis.
Okay, I definitely get the facial symptoms if that nerve chain is crushed. But what about the armpit pain?
That is called Pancoast syndrome.
Pancoast syndrome, right.
So the network of cervical nerves that exit your neck to supply sensation and motor function to your arm and hand, they travel right over the dome of the lung.
Just draped right over it?
Yeah, exactly. So an expanding apical tumor physically invades that nerve bundle. The patient will experience severe, really relentless pain radiating down their arm and into their armpit. And it's often misdiagnosed initially as just a shoulder injury.
That is fascinating. And there's more, right? A tumor in the right lung can also compress the superior vena cava.
Yes, the SVC. That's the massive vein draining blood from your head and arms back to your heart.
Right, so if that vein gets pinched off by a tumor, the blood backs up, and that causes profound swelling in the patient's face, neck, and arms.
Superior vena cava syndrome. And similarly, if a central tumor wraps around the recurrent laryngeal nerve, which is basically the wire powering your vocal cords, the patient's voice becomes permanently, inexplicably hoarse.
Unexplained hoarseness.
Yeah.
So because these symptoms mimic, neurological or vascular or even musculoskeletal issues, relying solely on clinical presentation is kind of a trap.
A huge trap. To truly find the cancer, we have to look inside the chest using advanced imaging.
Right. And a standard chest x-ray is the baseline, obviously, but the text makes it very clear that a CT scan is the absolute gold standard for seeing the structure.
Definitely. A CT scan gives us a high-resolution 3D map. It shows those irregular borders of the tumor and any enlarged lymph nodes.
But a CT scan is still essentially just shadows and lights, right? It shows us what is there, but not what the tissue is actually doing.
Exactly. It's morphological, not functional. To understand the function of that shadow, we rely on the PET scan.
So how does the PE scan work in this context?
Well, the patient is injected with a mildly radioactive glucose solution. And because malignant cells are multiplying at just a ferocious rate, their metabolism is in complete overdrive. They are basically starving for energy.
So they just gorge on the injected sugar water.
They do. They soak it up. And as they consume that radioactive glucose, the tumor brightly lights up on the scan.
Which is brilliant.
It is. It allows oncologists to differentiate between an active, dangerous malignancy and just a harmless, dormant nodule left over from, say, an old infection.
And what about MRIs? Do we use those?
We do use MRI, but primarily to scan the brain. The central nervous system is a very frequent sanctuary site for lung cancer cells to hide, so we have to check there.
Right. But even with the best imaging in the world, a glowing spot on a screen isn't a definitive diagnosis. You need physical tissue under a microscope. You need a biopsy.
Yes. Tissue is the issue, as they say.
Exactly. And the technique completely depends on where the tumor decided to set up camp. For those central tumors, the doctor performs a standard bronchoscopy, right? Threading a camera down the throat to look directly at the mass and just snip a piece.
Right. But standard bronchoscopes are too thick to reach the narrow distal branches of the lungs where those peripheral tumors hide.
So what do you do then?
This is where navigational bronchoscopy becomes vital. The medical team takes the patient's CT scan and uses it to map a virtual 3D route through the complex branching roads of the airways.
It sounds exactly like the GPS in my car, like mapping a route and find the exact address of the tumor.
That's exactly what it is. They essentially steer a flexible electromagnetic probe directly to that exact address of the peripheral nodule.
That is incredible. But what if the tumor is glued right to the inner chest wall, like super far out?
Then the radiologist might just skip the airways entirely. They use transthoracic needle aspiration, or TTNA. They guide a needle directly through the ribs from the outside into the tumor.
But the obvious risk there has to be puncturing the lung space, right?
Yeah, that's the main risk. If you puncture it inappropriately, air leaks out and you cause a pneumothorax, which is a collapsed lung.
Right. And getting a sample of the primary tumor is really only the first step, because the multidisciplinary team must also sample the mediastinal lymph nodes sitting in the center of the chest.
Crucial step. And for that, we use tools like endobronchial ultrasound, or EBUS.
EBUS?
Yeah, EBUS puts a tiny ultrasound wand right on the tip of the bronchoscope so the doctor can actually look through the opaque airway wall, locate those adjacent lymph nodes, and safely guide a needle right into them.
And if you're listening to this and wondering why we are so obsessed with getting these lymph node samples, well, it's because those nodes tell us if the cancer has started packing its bags.
Exactly. Has it mobilized?
Right. And that dictates the entire staging process. The sources emphasize a massive distinction here that I think is super important. Clinical staging versus pathological staging.
They are very different. Clinical staging is essentially our best educated guess. It's the battle map drawn up based on pre-surgery CTs, PET scans, and those initial biopsies.
Okay.
But pathological staging is the undeniable truth. It is the final report the pathologist writes after surgery, once they have the entire removed tumor and a handful of those surrounding lymph nodes sitting under their microscope.
And they formulate that truth using the TNM system. So T for tumor size, N for node involvement, M for metastasis. Let's break that down for the listener because it's not just a list of numbers. It's really a map of the cancer's journey.
Right. So for non-small cell lung cancer, Stage I means the tumor is localized and hasn't left the lung tissue at all. Stage 2 means the cancer cells have traveled down the lymphatic channels and invaded the nearby intrapulmonary lymph nodes.
So the perimeter has been breached.
Precisely. Stage 3 means the invasion has progressed even deeper, reaching the central mediastinal lymph nodes between the lungs. And then stage 4 indicates distant metastasis.
So the cancer has escaped into the bloodstream.
Yes, and set up colonies in distant organs, like the liver, brain, or bones.
And what about small cell lung cancer? Because that one spreads so aggressively.
Right. Small cell skips the complex numbers. It is staged simply as limited, meaning confined to one side of the chest, or extensive.
Got it. Okay, so once the medical team has the exact pathological stage, they deploy localized control. This is the physical removal or disruption of the primary tumor. Surgery is the gold standard for an outright cure, obviously, but the sources say only 10 to 35% of patients are actually healthy enough to endure it.
Yeah, because removing lung tissue permanently decreases a patient's oxygen capacity. You can't just take it out without consequences. So before making any incision, the surgeon orders rigorous preoperative pulmonary function tests. They literally have to mathematically prove the patient has enough reserve lung function to survive breathing with a fraction of their original tissue.
And the procedures scale with the disease, right? A total pneumonectomy removes the entire lung. A lobectomy, which I think is the most common procedure, removes just one distinct lobe.
Correct.
But then there is the sleeve lobectomy, which is it's a brilliant piece of anatomical engineering.
Oh, it really is a lung-sparing masterclass.
Yeah.
If a tumor is sitting right at the base of a lobe, invading the main airway pipe, the surgeon doesn't just take the whole lung.
Thank goodness.
Right. They remove the diseased lobe, and they just cut out the cancerous middle section of the main bronchus. Then, they sew the two healthy ends of the airway pipe back together, preserving all the healthy lobes below it.
But the text hammers home one non-negotiable rule for the operating room. The surgery is considered medically incomplete if the surgeon does not perform a lymphadenectomy.
Yes, absolutely critical. The surgeon is required to physically dissect and remove mediastinal lymph nodes during the operation.
And if they don't?
If they skip this step, the pathological staging will be deeply flawed. The patient might secretly have microscopic cancer in those nodes, and without knowing it, the oncologist won't prescribe life-saving postoperative chemotherapy.
Wow, so it changes everything.
It changes the entire treatment plan. And it's also worth noting the critical postoperative care. Patients must rigorously use an incentive spirometer.
Oh, that little plastic breathing device.
Yes, that simple breathing device forces the remaining lung tissue to fully expand, preventing fluid buildup and lethal postoperative pneumonia.
Okay, so if surgery isn't an option, or if the surgical margins weren't clean, we pivot to radiation therapy, which is utilized by roughly 50% of patients. We are essentially bombarding the chest with high-energy X-rays designed to shatter the DNA of fast-dividing cells.
Right, and historically, radiation was just a broad beam. It caused immense collateral damage to the heart and spinal cord.
But today we have better tech.
Much better. Today, we map the tumor in 3 dimensions using 3D CRT. We also use intensity-modulated radiation therapy, or IMRT.
How does IMRT work?
The radiation oncologist fragments the main beam into thousands of tiny individual beamlets. They can adjust the power of every single beamlet, effectively wrapping a lethal high-dose cloud of radiation tightly around the jagged edges of a tumor, while dropping the dose to near zero right next door at the spinal cord.
That is amazing. But here is what genuinely confuses me, though. A lung tumor isn't stationary. It is sitting inside a balloon that is constantly inflating and deflating.
Right, because the patient is breathing.
Exactly. So how on earth do you shoot a precise, tiny beamlet at a moving target without torching the healthy tissue it passes through?
It's a great question. We use image-guided radiation therapy combined with respiratory gating.
Respiratory gating.
Yeah, the computer system actually syncs with the patient's breathing cycle. It literally watches the tumor rise and fall. The machine turns the radiation beam on for a fraction of a second when the tumor inhales into the crosshairs and instantly shuts the beam off when the tumor moves away.
That is just sci-fi level medicine. And for early stage tumors in patients too frail for surgery, they use stereotactic radiation therapy, right? Delivering massive ablative doses in just a handful of sessions.
Yes, SRT.
Or brachytherapy, where a catheter drops radioactive seeds directly inside the airway to basically melt away a blockage from the inside out.
Exactly. But you have to remember, surgery and radiation are localized weapons. They only treat the visible battlefield.
Right.
Lung cancer is notorious for shedding microscopic pioneer cells into the bloodstream long before the primary tumor is even found. So to hunt those down, we need systemic control.
And Historically, systemic control just meant traditional chemotherapy, which is, let's be honest, a blunt instrument. It is a systemic cytotoxin that circulates through your veins and kills absolutely any cell that happens to be dividing rapidly.
Which perfectly explains its devastating side effect profile. It doesn't just kill cancer cells.
Right. Hair follicles are some of the fastest dividing cells in the body, which is why patients lose their hair. The lining of the gastrointestinal tract replaces itself constantly, so chemo destroys it, causing severe nausea and diarrhea.
And the mucous membranes in the mouth break down, causing painful ulcers known as stomatitis. It also suppresses the bone marrow, destroying red and white blood cells.
Leading to profound fatigue and an extreme vulnerability to infection.
Exactly. And because of this intense toxicity, chemotherapy is administered in cycles. You hammer the body to catch cancer cells in their active division phase, and then you pause. You have to allow the healthy tissue to recover before the next strike.
And chemo can be given as neoadjuvant therapy, right? To shrink a massive tumor before surgery, or adjuvant therapy to mop up rogue cells after surgery.
Right. But the textbook details a massive, relatively recent paradigm shift away from that blunt force approach. We are now in the era of personalized medicine, specifically targeted therapy.
Which benefits about 15 to 20% of NSCLC patients.
Yes. So instead of carpet bombing the body, we biopsy the tumor and sequence its DNA. We're looking for the specific genetic glitch driving the uncontrollable growth. Mutations like EGFR, ALK, ROS1, or BRAF.
So if a patient has an EGFR mutation, the cancer cell is producing a mutant protein that is constantly screaming, divide, multiply.
Exactly.
So we can give the patient a targeted drug, often just a daily pill they take at home, that physically plugs up that specific protein receptor. The cell stops receiving the signal to divide, and the tumor quietly shrinks.
This is remarkably elegant, and it totally spares the healthy tissue. Though, unfortunately, the cancer could eventually mutate a new pathway around the drug.
Always trying to outsmart us. Which brings us to arguably the most astonishing breakthrough, immunotherapy.
Yes.
This is used as a first-line defense for nearly 30% of advanced patients. And to understand this, you have to understand how cancer hides. Your immune system has T cells constantly patrolling the bloodstream, looking for mutated cells to destroy.
Right.
But cancer cells are incredibly deceptive. They coat their exterior in a protein called PD-L1.
And PD-L1 is an inhibitory checkpoint. When a patrolling T cell bumps into a cancer cell coated in PD-L1, the protein binds to the T cell and sends a signal that basically says, stand down, I'm healthy tissue.
The cancer actively pacifies the immune system. So the cancer cell uses PD-L1 like an invisibility cloak or, a fake ID to sneak past the immune system's bouncers.
I love that analogy.
And the crazy part is immunotherapy drugs don't actually kill the cancer at all. The drugs are designed to bind to the PD-L1 protein, neutralizing it. They essentially rip away the fake ID.
Yes. And suddenly, the body's own immune system realizes it's staring at a lethal tumor, and the T cells just go to war.
It is a profound mechanism. However, because these drugs are taking the breath off the patient's immune system, the side effects are entirely immune-related.
Right. The hyperactive T cells can become confused and attack healthy organs, causing severe inflammation like hepatitis in the liver or colitis in the gut.
We have dissected this disease down to the molecular receptors today, but the final chapters of the text pull back to a critical, holistic view. Because medical professionals cannot just treat a glowing scan, they have to treat the terrified human being sitting in the exam room.
Absolutely. The psychological burden of a lung cancer diagnosis is incredibly unique. Many patients are crushed by smoker's guilt, internalizing this profound shame that they brought this terminal illness upon themselves.
And addressing that stigma and providing robust emotional support is just as critical as prescribing the right chemotherapy.
It really is. And from a clinical standpoint, doctors must aggressively push for smoking cessation, even after the diagnosis.
Right, because it's easy to understand why a patient might think, well, I already have cancer, the damage is done, why suffer through nicotine withdrawal right now?
But the medical data demands cessation. Quitting smoking immediately alters the clinical trajectory. If you need surgery, quitting reduces airway mucus, meaning less time on a post-operative ventilator and a vastly lower risk of pneumonia.
And quitting actually alters blood flow and oxygenation, which improves the sheer chemical efficacy of your chemotherapy and radiation.
Furthermore, if a patient beats their cancer, they face a 2 to 3% compounding risk every single year of developing a second entirely new primary lung cancer. Stopping smoking is literally the only way to arrest that ongoing molecular damage.
The text also redefines palliative care, which I found so interesting. The general public often equates palliative care with end-of-life hospice, like giving up the fight.
Yeah, that's a huge misconception.
But the data shows that introducing palliative care, which is focused entirely on aggressive symptom management and quality of life, at the exact moment of diagnosis, actually prolongs patient survival compared to standard care alone.
Because keeping the patient strong, comfortable, and nourished allows them to endure more cycles of life-saving therapy.
Wow.
Now, before we wrap up this session, let's test your clinical reasoning to reinforce what we've mapped out today. Imagine you are the clinician. A patient presents with a drooping right eyelid, a constricted right pupil, and severe, unrelenting pain radiating down the right arm and into the armpit.
Okay, the detective work.
Exactly. Based on the anatomical pathways we discussed, where exactly in the lung is this tumor located, and what is the specific name of the syndrome causing that arm pain?
All right, so if you follow the nerve pathways we talked about, you know that the tumor is sitting right at the apex, the absolute crowded top of the right lung.
Right. Compressing the sympathetic nerve chain creates the facial symptoms of Horner syndrome, while invading the cervical nerve bundle, traveling over the dome of the lung triggers that severe arm pain known as Pancoast syndrome.
Amazing. We have journeyed from a single glitching cell to complex sleeve lobectomies and the molecular removal of invisibility cloaks. It leaves me with a profound thought to chew on. As medicine moves rapidly away from the blunt force trauma of traditional chemotherapy and steps further into the era of hyperspecific genetic targeting and immunotherapy, are we witnessing the exact historical moment where lung cancer transitions from a definitive terminal diagnosis into a manageable chronic genetic condition?
It's entirely possible.
It is a remarkable, hopeful thought to carry with you on your next deep breath.